Welcome back, everyone, to the second part of our imaging for the cardiac surgeon lecture. So this lecture will be about congenital heart disease imaging. I will start again with a question. So a 30-year-old woman with repaired tetralogy of Fallot in early childhood and severe pulmonary regurgitation on transthoracic echocardiography is referred to you for consideration of pulmonary valve replacement. Transthoracic echocardiography also shows a dilated right ventricle with a RV systolic pressure of 43 millimeters of mercury. The peak RVOT gradient is 10 millimeters of mercury. She has a normal exercise tolerance for age and no history of arrhythmia. Which of the following imaging is the most likely to help you to decide if surgery is indicated? So A, transesophageal echocardiography, B, a cardiac cath, C, CMR, or D, a pulmonary artery CTA. So today we'll discuss a little bit about when to use CMR instead of echo for congenital heart disease. Then we will discuss congenital aortic valve disease, hereditary aortopathy, coarctation. We will look at the differential diagnosis of the dilated right ventricle. Then we will discuss about tetralogy of Fallot, congenital mitral valve disease. We will review shunts, mostly ASDs and VSDs, anomalous pulmonary veins. We will describe the imaging of the atrioventricular canal, and we will finish with an overview of more complex disease such as transposition of the great arteries and univentricular hearts and Fontan circulation. I will also tell you a little bit about anomalous coronaries. So when is CMR more advantageous than echo for imaging congenital heart disease? So of course, when there are suboptimal echo windows, if you need precise ventricular volumes, if you need to assess systemic and pulmonary venous connections. For the specific imaging of a repaired tetralogy of Fallot, there is a lot of attention given to RV volumes and to pulmonary regurgitations. RV2PA conduits are difficult to see on transthoracic echocardiography, as is the calculation of QP over QS ratio. If you need imaging of the complete thoracoabdominal aorta or to look for aortopulmonary collaterals, for that particular indication, CTA is advantageous because of higher spatial resolution. If you need to study the course of an anomalous coronary, we can use coronary MRA. However, CTA has much higher spatial resolution and has a much shorter acquisition time. And finally, CMR is advantageous if there is a need for myocardial tissue characterization, so to look for fibrosis, to look for fat, or to look for iron. These are examples of the anatomical variabilities of the aortic valve. So the normal aortic valve is tricuspid. This is a transthoracic short axis view with the right coronary cups on top, the non-coronary cusp facing the interatrial septum, and the left coronary cusp here. If the valve has a single commissure, it is a unicuspid valve, and therefore the opening will be in the shape of an omega, as this example in the top left. If the valve is bicuspid, then the opening will be in the shape of an ellipse. And if the valve is quadricuspid, which is the least common type, the opening will be in the shape of a square. Abnormal aortic valves will usually produce eccentric aortic regurgitation. So just by looking at the direction of the jet of aortic regurgitation, you can have a clue that the aortic valve is morphologically abnormal. For example, in a bicuspid aortic valve, the conjoined cusp will often prolapse, leading to eccentric aortic regurgitation. By opposition, in rheumatic aortic regurgitation, the leaflets are often evenly thickened, leading to a central jet of regurgitation, as is the case in in patients with enlargement of the aortic root with a central jet of aortic regurgitation. Bicuspids or abnormal aortic valves are associated with an aortic aneurysm, and over a follow-up of 9 to 16 years, you see that the prevalence of aortic aneurysm increases. They are also associated with aortic events, mostly in the form of aortic surgery, but also in a few cases of aortic dissections. Congenital aortic valve disease may manifest clinically as stenosis or regurgitation. It also manifests as aortic dilatations, which may not occur at the same time as the valve dysfunction. So over longitudinal follow-up, it's important never to lose track of the possibility of aortic dilatation. If you're shown a case of congenital aortic valve disease, you need to think about the advantages and disadvantages of various forms of aortic valve replacement. Remember that bioprosthetic valves usually are associated with the need for reoperation in younger patients, but they do not need anticoagulation. In contrast to mechanical prostheses, who are very durable but require lifelong anticoagulation. The Ross operation is a very interesting option in young patients. However, it is more complex and technically demanding. It is said to transform a single valve disease in a two-valve disease, but it does not require anticoagulation. It seems to be quite durable, at least for the pulmonary autograft in the aortic position, and it offers a good protection against endocarditis. If the patient is a young woman, you always need to factor in pregnancy planning. So let's look at another case, this time a 41-year-old man with aortic dilatation. He has been followed in childhood, then lost to follow-up. He presents for review at the insistence of his family. He has a diastolic murmur, 3/6. Physical exam also reveals pectus carinatum, a high arch palate, positive thumb and wrist signs, and also skin striae. On transthoracic echo, his aortic root is 68 millimeters with 2+ aortic regurgitation. So what is the diagnosis in this patient with an enlarged aortic root and syndromic features? So you may have guessed by now that he has features of Marfan syndrome. So this is a framework to make a differential diagnosis in patients with aortic aneurysms and dissections. If the patient is less than 65 years old or has a family history, then you have to look for systemic features, joint hypermobility, ocular disease, the presence of a bicuspid valve, a known gene or anomaly in the family. And if the patient has one of these syndromic features, then you should consider Marfan syndrome or Lewis-Dietz syndrome, perhaps Turner syndrome in women with primary amenorrhea, or vascular type Ehlers-Danlos syndrome. On the other hand, if there is a family history but no syndromic feature, you may be dealing with the patient with familial thoracic aortic aneurysms and dissections. And then the genes to consider are mostly ACTA2, MYH11, and there are now up to 30 genes that have been reported associated with familial aortic aneurysms. The bicuspid aortic valve is a strange disease because it is more common in patients with FTAD, but it is also more common in patients with a syndromic aortopathy. On the other hand, a patient with multivessel atherosclerosis and aortic calcifications more likely has aortic atherosclerosis than a genetic aortic disease. CMR can provide a comprehensive evaluation in a patient with aortic root disease. So this is our patient with a 68 millimeter aortic root aneurysm. This 3D rendering of the aortic MRA shows that the disease is limited to the aortic root. You see here that there is a jet of aortic regurgitation, and if we place a CMR flow study in the aortic root, we obtain the following flow curve with forward flow and holodiastolic flow, and if you do the area under the curve in diastole over the forward flow, you get the regurgitant fraction, which is 42%, consistent with severe aortic regurgitation. This is a short axis view of the aortic valve, reproducing the echocardiographic view, and you can appreciate that the aortic valve is tricuspid. The patient underwent a Yacoub operation, which is a valve-sparing aortic root replacement that can be combined with an ascending aorta replacement if needed. Why is aortic size so important? Well, the incidence of aortic events increases with an increasing aorta diameter. Therefore, it is very important to have accurate aorta measurements to decide if surgery is indicated. It's also important to measure the aortic root at consistent landmark. So the first landmark is the aortic annulus, and we know by now that from the TAVR literature that the aortic annulus is not round but shaped like an ellipse. Then the sinus of Valsalva is usually the part with the largest diameters. It is often reported with 2 or 3 diameters. It is followed by the sinotubular junction. If it's effaced, it may be associated with more aortic events. Then the proximal and distal ascending aorta. It is important to measure the aorta en face, because if the aorta is measured on a straight axial view, as it is in this case, the vessel may be cut obliquely, leading to overestimation of the diameter. So in this example, it's the same aorta. If it's measured in straight axial, the diameter is 53 millimeter. But if it is measured truly en face with multiplanar reconstruction, then the diameter drops to 48 millimeter. So this patient would go from a surgical patient to a careful observation patient just by changing the method of measurement if the surgical threshold is set at 50 millimeter. It is always useful to obtain orthogonal views of the aortic root. This is an example of a repaired tetralogy of Fallot. You can see that the aorta is overriding the septum. There is a VSD patch here, and there is enlargement of the aortic root, which can occur up to 29% of patients with the tetralogy of Fallot. Moving further down in the aorta, the most common congenital heart disease of the descending aorta is aortic coarctation. This is an aortic arch sine, and you can see that there is systolic turbulence here corresponding to a discrete narrowing. This is a very typical presentation of a coarctation in an adult. There is dilatation of the left subclavian artery, an isthmic coarctation, and you see collaterals feeding the descending aorta. Coarctation is a short segment narrowing in the region of the ligamentum arteriosum. It is associated with tubular hypoplasia or interruption of the aortic arch or isthmus. It is defined as a peak-to-peak gradient above 20 millimeters of mercury. On echo, we often use a corrected peak gradient to account for proximal velocity, because if the stenosis is tubular, then the Bernoulli equation, which is designed for discrete stenosis, does not apply. Some readers will report a mean Doppler systolic gradient. If it's above 20 millimeters, then the peak gradient will of course be about 20 millimeters. So it's just it just indicates a more significant obstruction. And imaging gradients should be correlated to clinical gradients, which can be obtained by the difference between upper and lower limb blood pressure, which is significant above 10 millimeters of mercury. Remember that extensive collateralization may mask the severity of obstruction. The collaterals often come from the internal thoracic and intercostal arteries. Patients who have undergone coarctation repair may have late complications such as recoarctation, a true or false aneurysm at the repair site, aortic dissection, or endarteritis. They can also have residual lesions that include a bicuspid aortic valve, aortic stenosis or subaortic stenosis, aortic regurgitation, aortic arch hypoplasia, mitral valve abnormalities, a VSD, or coronary artery disease. There is a body of literature that linked a higher incidence of coronary artery disease in patients with coarctation, although this is being questioned. This is an example of an echocardiogram in a patient with coarctation. So this is a suprasternal view. You see the ascending aorta with branching vessels. And with color Doppler, you see that there is acceleration toward the aortic isthmus, which seems to be somewhat tortuous. There could be a cavity around here with circulating flow. With continuous wave Doppler, the peak gradient is 70 millimeters of mercury. The mean gradient is 51 millimeters of mercury, so consistent with a very severe obstruction. This is the formula to measure the corrected peak gradient. So instead of doing 4v square, which is the short version of the simplified Bernoulli equation, we add a term accounting for the proximal velocity, so the velocity measured before the obstruction if there is a tubular stenosis. CMR, on the other hand, is not subject to the dependency on the proximal velocity. So if we place a flow study perpendicular to flow in the aortic isthmus, we can produce a flow curve just like this one. The peak velocity on this flow curve is 3.3 meters per second. That can be transformed using the simplified Bernoulli equation in a peak gradient of 44 millimeters. So again, 44 millimeters of mercury. So again, a very significant obstruction. You always need to be mindful that patients with coarctation may have gone a prior repair. Although now more and more coarctations are treated percutaneously with stents, even in younger children, small stents can be put in and then expanded at several times during growth. The preferred surgical intervention is end-to-end is coarctation resection with end-to-end anastomosis, because this allows growth of the aortic isthmus. Interposition grafts are usually reserved for adults because otherwise the aorta would grow and the graft will remain small. The same goes on for patch angioplasty, although a particular type of angioplasty can be used in children, which is called a subclavian flap. The subclavian artery is used to augment the aortic isthmus, sacrificing the proximal part of the left subclavian artery, which will reconstitute distally with collaterals. So these patients will have a reduced or absent pulse in the left upper limb, and on imaging you will see that that this part of the subclavian artery will be absent. There is also the possibility to do an ascending to descending aorta graft in patients with complex coarctation. For example, in this case, there is severe recoarctation and a large aneurysm at the coarctation repair site. So this patient was operated with staged procedures, first creating the graft and then resecting the aneurysm. Moving on now to the problem of the dilated right ventricle. So if you see a dilated right ventricle, you should always look at the septal curvature. So these are cine CMR image, but they could be an echo image. So if you see that there is diastolic flattening of the septum or a diastolic D shape of the left ventricle, this is indicative of RV volume overload, and the differential diagnosis that should open includes any form of atrial septal defect, pulmonary regurgitation, or tricuspid regurgitation. On the other hand, if there is systolic and diastolic D shape of the left ventricle, this is indicative of RV pressure overload, and then the differential diagnosis should be pulmonary hypertension, RVOT obstruction, pulmonary embolism, or the presence of a systemic or subaortic right ventricle, as is the case in this example. This is a 30-year-old female who is at 31 weeks of a first pregnancy. She presents with non-sustained ventricular tachycardia. She had an unknown defect repaired at age 2. She is said to have pulmonary stenosis, enlarged right-sided chambers, and a right ventricular systolic pressure of 30 millimeters of mercury. What is wrong with this presentation? Well, first, it would be surprising to have substantial pulmonary stenosis with only 30 millimeters of mercury in the RVSP. And then if we look at the echo images, you can see here in short axis that there is diastolic D shape of the left ventricle and an enlarged right ventricle. So this should suggest RV volume overload, not RV pressure overload. And if you look at the parasternal long axis view here, there is the right ventricle on top, the aorta, the left ventricle, and the left atrium. You can see that the aorta overrides the septum, and there is a hyperechogenic structure here that looks like a patch. So you probably know where I am going to. This is a patient with a repaired tetralogy of Fallot and some kind of a volume loading lesion on the right side of the heart. The most common reason for RV volume overload in repaired tetralogy of Fallot is severe pulmonary regurgitation. So this is a RVOT view with color Doppler. You see the right ventricle on top, and this is the main pulmonary artery. You can guess that there is bifurcation here, and you see that there is both a forward and backward, especially a backward orange flow starting almost into the RPA here. Using a continuous wave Doppler, you see that there is a triangular shape of the diastolic flow with a sharp and rapid decrease in pressure. This corresponds to a pressure F time of 53 milliseconds and a peak velocity of only 8 millimeters of mercury. So there is no substantial obstruction here, but severe pulmonary regurgitation. As you get more information, you learn that the patient was cyanosed at birth, that a hole was patched, and that a valve or artery was opened at 2 years old, and she had no follow-up since then, and she did well until recently, confirming your impression that this is repaired tetralogy of Fallot. So tetralogy of Fallot, as it says, it has 4 components: infundibular pulmonary stenosis, right ventricular hypertrophy, a large malalignment VSD, and septal override of the aortic root. When it is repaired, the VSD is patched, usually committing a little bit of the right ventricle to the aorta, with the aorta overriding the plane of the septum. The RVOT is opened with infundibulectomy, sometimes pulmonary valvectomy, and if the annulus is too small, a transannular patch is used to augment it, creating free pulmonary regurgitation. Patients with tetralogy of Fallot repair have a lot of potential complications besides RVOT complications. They can get pulmonary hypertension, biventricular dysfunction, atrial and also ventricular arrhythmias, endocarditis, a residual VSD, aortic valve, and tricuspid valve disease. This is to show you the difference between the continuous wave Doppler in patients with severe pulmonary regurgitation in comparison to moderate pulmonary regurgitation. So it has to do with with measuring the pressure F time. So the time it takes for the pressure to drop by half in diastole. And if it's less than 100 millisecond with a triangular signal, then this is suggestive of severe PR. In this example, with moderate pulmonary regurgitation, the signal does not return to the baseline by the end of diastole. Remember that pressure F time, whether it is mitral or pulmonary, is influenced by the compliance of the two chambers. So in this case, the RV compliance and the PA compliance. If one wants a more quantitative estimate of pulmonary regurgitation, we can use CMRs. This is a RVOT view, so right ventricle, pulmonary artery, and you see in diastole that there is a large jet of pulmonary regurgitation. By placing a flow study in the main pulmonary artery, we can obtain the following flow curve, very similar to the aortic regurgitation curve that we saw earlier in the Marfan case. And if we do the area under the curve in diastole over the forward flow, we get a regurgitation fraction of 48%, which is severe. CMR also allows the precise measurement of ventricular volumes by slicing both LV and RV in 8 millimeter slices with no interspace, and then using the Simpson rule or the summation of discs, a volume can be estimated. There is a large volume of literature using RV size to predict outcomes in tetralogy of Fallot. Although this is being questioned, traditionally, if the RV and diastolic volume index is above 160 or the RV and systolic volume index is above 80, then a pulmonary valve replacement should be considered in patients with repaired tetralogy of Fallot. Another component of imaging in tetralogy of Fallot that has been given more and more attention is the presence of fibrosis or scars. So we have seen the use of late gadolinium enhancement for myocardial infarction imaging in the first lecture. So if there are areas that are scarred in the right ventricle in patients with tetralogy of Fallot, this is associated with a higher risk of arrhythmia and sudden death. Typical areas that will have fibrosis is the RVOT transannular patch or the VSD patch. In this case, this is a RV to PA conduit. You see the LV here, the RV is here, and there is artifacts because there is a sternotomy. And this is the fibrosed conduit. Moving to another case, a 22-year-old with dyspnea on exercise. So this is a transesophageal echocardiography. You see that the left atrium is on top, the right atrium is below. The right atrium is enlarged. This is the opening of the SVC, which is overriding the atrial septum. And by color Doppler, you see that there is a left to right shunt through that defect. So this is the typical appearance of a superior sinus venosus atrial septal defect. It's a defect in the superior part of the interatrial septum. There is no superior margin of between the interatrial septum and the superior vena cava, and it is often associated with anomalous pulmonary venous connection, as in this case, the right upper and the right middle pulmonary veins drain into the SVC just above its junction with the right atrium. So whenever you see a sinus venosus ASD, you should define the pulmonary venous anatomy. There are 4 types of atrial septal defects. So in addition to the sinus venosus defect, the most common defect is the secundum atrial septal defect. It is usually in the middle part of the interatrial septum. This is an example of a subcostal view. The left atrium is at the bottom of the screen. The right atrium is at the top of the screen, and you see a color jet going toward the probe, so an orange jet from the left atrium to the right atrium. A primum atrium septal defect is a part of an AV canal, and a coronary sinus ASD, or an unroofed coronary sinus, is the least common type. It usually leads to a large shunt because there is no partition between the left atrium and the coronary sinus. An atrial septal defect will lead to RV volume overload. It can lead to pulmonary artery dilatation because of increased flow, which can be measured. And whenever you find an ASD, as a reminder, you should always define pulmonary venous anatomy. This is another example of a shunt. So this is a young adult with an enlarged left atrium and left ventricle. So you can see here that there is a high velocity color flow through the septum. If you put a continuous wave Doppler, you obtain a very high gradient. This is a muscular Vsd, which can be suitable for surgical or percutaneous closure. Remember that the indications for closure include symptoms, left heart dilatation, LV dysfunction, more than moderate aortic regurgitation for subarterial or perimembranous VSDs, a significant shunt, pulmonary hypertension, or a history of endocarditis. These are other examples of congenital ventricular septal defect. So this is a short axis view. The aortic valve is in the middle. This is the RVOT and pulmonary valve, and you see a color jet between the LV and the RV below both the aortic and the pulmonary valve. So this is a subarterial VSD or an outlet VSD, as opposed to a perimembranous VSD, which is on the other side of the same short axis view. It is below the aortic valve and the tricuspid valve. It is often partially closed by a membranous septal aneurysm, where you can see, which is the tricuspid tissue trying to close the defect. But often there is a residual shunt in the area of the apex of the aneurysm. As a summary, if you see dilated heart chambers and you're dealing with a potential shunt, if the dilatation involves the left heart, then you should look for a VSD or a patent ductus arteriosus. If the dilatation involves the right heart, you should look for an atrial septal defect. A particular type of atrial septal defect is the complete AV canal. Is the partial or complete atrioventricular canal. So if the defect is limited to a primum type ASD, then it's a partial AV canal. If the defect involves a large VSD in the continuation of the primum ASD, then it's a complete AV canal. Because the AV valve is a single AV valve with variable degrees of septations between the right and left AV valves, you can have incompetent commissures known as the mitral valve cleft or the left-sided AV valve cleft. So this is an example of a short axis view of the atrioventricular valve in a patient with a complete AV canal. You see that the valve has actually 5 leaflets. This is a graphical depiction, and the mitral cleft is an incompetent commissure between the lateral leaflet and the anterior leaflet. This is an anatomical depiction, and this is a long axis CMR view of the same common AV valve. You see that this patient has a common atrium, which is a form of atrioventricular canal. There is no VSD in this case, but the inlet VSD would be here, and you see that there is a substantial thinning of the septum, and you see that there is the common AV valve. This is an example of a patient with a repaired complete AV canal. So you see that this looks a little bit more like normal anatomy than the previous case. There is a patch here closing the atrial septal defect, which is close to the AV valves. There is another patch here closing the VSD, the inlet or AV canal VSD. And you see that there is a posteriorly directed jet of regurgitation of the left AV valve. These are echo views in the short axis plane of the left AV valve in the same patient. You see that when the valve opens, there is a defect here corresponding to the commissure between the anterior leaflet and a posterior or right-sided leaflet, and it is this incompetent commissure that is actually the mitral cleft. And there is a jet of mitral regurgitation or a left-sided AV valve regurgitation going through this defect. Moving to another case, a 25-year-old woman, 20 weeks pregnant with a loud murmur and exercise cyanosis. This is a subcostal view. You may remember this view. This is the right atrium, the left atrium, and there is a large colored jet going from the left atrium to the right atrium. If you actually put an M mode through that, you realize that the flow is bidirectional. So there is a right to left and also a right to left shunt, which is the blue flow going from the right atrium to the left atrium. So the typical shunt in an ASD is left to right. So why does this patient need to decompress a right atrium through the ASD? Well, the explanation is in the RVOT view here, where the pulmonary valve is thickened and doming with a high velocity jet through it, corresponding to a peak velocity of 6.2 meters per second and a peak gradient of 153 millimeters of mercury. So very severe pulmonary stenosis, resulting in increased right-sided pressure decompressing to an ASD, through an ASD. To remind you that the pulmonary stenosis severity can be graded both using the peak continuous wave gradient or the right ventricular systolic pressure. Although a severe stenosis is typically above 64 or 65 millimeters of mercury, and an intervention should be considered whenever the gradient reaches 50 millimeters of mercury. Moving on now to more complex disease, with a complete transposition of the great arteries, there are two options to repair DTGA. In the past, surgeons would perform atrial switch operations that will leave the systemic the right ventricle in the systemic or subaortic position. But nowadays, the arterial switch operation, restoring the left ventricle as a systemic ventricle, is favored. This is a graphical depiction of the mustard operation, which is a complex operation where the systemic venous blood is rerouted through a baffle to the mitral valve, the left ventricle, and the pulmonary artery. And the pulmonary venous flow is rerouted from the posterior part of the left atrium to the tricuspid valve and into the subaortic or systemic right ventricle. These are graphical depictions of the common systemic venous baffle and the pulmonary venous baffle. You see that there are walls that are surgically created between these baffles, and these can be the sites of baffle leaks. In a mustard operation, these baffles are created with pericardial tissue. They are created with atrial tissue in a setting operation, but the physiology is the same. After an atrial switch, patients may have RV dysfunction, tricuspid regurgitation, which I remind you will be the systemic AV valve regurgitation, a baffle leak leading to a right to left shunt. The shunt is usually right to left because baffles are rigid and the pressure in the baffle may be higher than the systemic atrial pressure. There can be a venous conduit stenosis. The most frequent site is at the SVC to atria junction. There can be post-capillary pulmonary hypertension, which is due to the baffle rigidity and also to diastolic dysfunction of the systemic right ventricle. There can be dynamic subpulmonary obstruction, pulmonary vein or pulmonary baffle stenosis, and pulmonary vascular disease in a small percentage of patients. This is a CMR depiction of the common systemic venous pathway in a patient with a mustard operation. So you see the SVC joining the common pathway and the IVC joining the common pathway. This cavity, which is posterior, is the systemic atrium where the pulmonary veins drain, and it will cross actually to become anterior and drain into the tricuspid valve. This is another example. So in the sagittal view that we were looking at on the previous slide, this is the part of the systemic venous atrium that was lying posterior to the common systemic venous pathway. So the pulmonary veins are draining into the systemic atrium, leading to the tricuspid valve and the systemic right ventricle, which is hypertrophied, and the vena cavas drain into this common pathway, draining into the mitral valve and the subpulmonary left ventricle. It is always important to define coronary anatomy in patients with detransposition of the great arteries, because these arteries need to be translocated in a neonate undergoing an arterial switch operation. So remember that in this native anatomy, the aorta will be anterior to the pulmonary artery, and typically the left coronary artery and the right coronary artery will originate from the aortic sinuses that are facing the pulmonary valve. So after an arterial switch operation, the coronary arteries are translocated to the neo-aortic root, but in the native anatomy, this was the pulmonary root and this was the aortic root. In the arterial switch operation, there is transection of the arterial trunks and reanastomosis to the contralateral trunk. I've explained that there is coronary artery transposition. And also the distal ascending aorta is placed posterior to the pulmonary bifurcation. So that means that the pulmonary arteries will be stretched to bring the pulmonary root anterior to the aorta. The PA branches will wrap around the ascending aorta like two arms put around a tree, and the left ventricle will be back in the systemic position. This procedure is called the Leconte maneuver, and I will show you the typical imaging appearance of a Leconte maneuver. Arterial switch patients tend to do very well. They 95% have normal left ventricular function. They can have stenosis of the neopulmonary artery. The RVOT and pulmonary artery can be distorted due to the Leconte maneuver. Especially early on after surgery, there can be occlusion of the coronary ostia, and therefore the coronary arteries should be studied in any patient with decreased LV function. There can be dilatation of the neo-aortic root or neo-aortic valve regurgitation. The Leconte maneuver can cause neo-aortic coarctation, and the incidence of arrhythmias is typically low. So this is an example of the Leconte maneuver. So this is the neo-aorta, this is the neo-pulmonary artery, and you see that the pulmonary arteries wrap around the ascending aorta. So if this is, if these arteries are stretched, they can become stenotic, especially at the point where they cross the ascending aorta. This is a sagittal view showing pulmonary stenosis after a Leconte maneuver. So you see that the aorta is directly anterior, that the pulmonary artery is directly anterior to the aorta in a sagittal view. So the chest is here, the back is here. Finally, the Rastelli operation is another way to restore the LV into the systemic position if there is subpulmonary stenosis, therefore precluding an arterial switch operation. So the left ventricle is tunneled through the VSD to the anterior aorta, and the tunnel patch closes the VSD, and there is a conduit that is put between the RV and the pulmonary artery. So these patients must undergo conduit dilatation, stenting, or replacement, usually at several times during their life. The patients with a Rastelli operation have more left ventricular dysfunction, more arrhythmias than patients with arterial switch. As I said, there can be a progressive RV2PA conduit dysfunction. The LV tunnel can become obstructed, leading to dyspnea and syncope. They can have endocarditis and also aortic root dilatation with aortic regurgitation. This is an example of a Rastelli operation by CMR. So if you look at this stack, the right ventricle is anterior, the left ventricle is posterior, and you see that the left ventricle is tunneled to the aortic root, and that there is a conduit that leaves the apex of the right ventricle reaching the pulmonary artery bifurcation. You can see the VSD patch here. This is the same view in a short axis. So you see the left ventricle, the right ventricle. You see that there is a conduit with aliasing, indicating a gradient coming out of the right ventricle. The left ventricular outflow is here, reaching the anterior aorta. And with one more look, you can see the VSD patch, which is here. This is a 3D rendering of an MRA showing the tunnel between the left ventricle and the aorta. Moving now to a much less common type of transposition of the great arteries, which is the congenitally corrected transposition of the great arteries, or double discordance. So in this anatomy, AV and VA discordance will correct the pathway of blood flow. Therefore, this can go unrecognized until adulthood because there is no cyanosis. However, there are many associated conditions. Many of these patients will have mesocardia or dextrocardia. 75% will have a VSD or a pulmonary stenosis. The tricuspid valve, which is the systemic atrioventricular valve in that anatomy, is often congenitally abnormal. It often looks like an Epstein valve, mostly because it is apically displaced, and it can become dysfunctional with systemic AV valve regurgitation. This systemic AV valve regurgitation can volume load the systemic right ventricle and starting a vicious circle leading to heart failure. Patients with CCTGA are at risk of congenital AV block. They have a risk of 2% per year of developing AV block. They are at risk of systemic RV dysfunction, and they can also have atrial arrhythmias. So this is an example of a CCTGA. So the right ventricle that you can recognize with the moderator band is on the left side. The apically displaced tricuspid valve has at least moderate regurgitation. And you see here that this is a left ventricle with a smooth septal surface and a competent mitral valve. But this ventricle, as you can see in this stack, is draining into the pulmonary artery, while the right ventricle is draining into the aorta. This is a long axis view showing the ventriculo-arterial discordance in LTGA or CCTGA. So this is the hypertrophied systemic RV pumping into the aorta, and the hyperdynamic subpulmonary left ventricle pumping into the PA. When you have only a single functional ventricle, you have only one choice but to commit it to the aorta. Therefore, patients with univentricular hearts do not truly have a single ventricle because there are always two ventricles. One of them can be hypoplastic. Need to have some form of correction that will create that will commit the functional ventricle to pumping into the aorta, and will allow passive filling of the lungs directly from the systemic veins. And this is the concept of the Fontan operation. Here you can see an example of Tricuspid Atresia, where there is no functional RV cavity, which was repaired by a classic atriopulmonary or RA-to-PA Fontan. So all the systemic venous flow filled the PA directly from the right atrium. Venous return is to the left ventricle pumping into the aorta. So these are examples of functionally single ventricle. This is a double inlet left ventricle with two AV valves draining in a large dominant left ventricle and a diminutive right ventricle anteriorly. This is an example of a tricuspid atresia. You see a blind right atrium with adipose or fatty replacement where the tricuspid valve should be, and a very small anterior RV. This is a double outlet right ventricle. So you see this is the left ventricle, which is quite small. And here you see the right ventricle with two parallel great vessels coming out. Here in short axis, you can appreciate that there is a muscular conus or infundibulum below both the great arteries. The Fontan operation has been performed in many types over the years. So the classic RA to PA Fontan is no longer performed. It has many years ago given way to the intracardiac lateral tunnel Fontan with the superior cavopulmonary anastomosis, and a little bit more recently to the complete extracardiac Fontan that can be done without touching the heart. The problem with that is that there is no longer a venous access to the heart from the femoral root. Patients with the Fontan operation can have many complications, including atrial arrhythmias, thromboembolism, protein-losing enteropathy, systemic AV valve regurgitation leading to a rise in Fontan pressure and potentially eventually to Fontan failure. The Fontan conduits can be obstructed. There can be ventricular dysfunction. Nearly all patients with the Fontan operation will have some form of cirrhosis or hepatic dysfunction. A rarer complication is plastic bronchitis. And a lot of these patients will have cyanosis because they have pulmonary to systemic to pulmonary venous collaterals. These are CMR examples of the three types of Fontan connection. So this is a classic RA to PA Fontan with a widely patent anastomosis. This is an intraatrial lateral tunnel Fontan conduit. And this is a extracardiac Fontan. In echocardiography, it is hard to see the Fontan anastomosis or the Fontan conduit. We only see parts of the conduit, so we can only assess the patency of the Fontan circuit by indirectly looking at the transmission of the respiratory variation to the pulmonary arteries. And now our last case of congenital heart disease. This is a 22-year-old female college student with progressive dyspnea for 2 years and non-anginal chest pain. She has a apical murmur 2/6 and her chest x-ray is normal. So she undergoes the following echocardiography. This is a modified RVOT view. So you see a orange jet that seems to be draining into the pulmonary artery. Here, with the probe displaced a little bit down from this view, you see that this is the takeoff of the right coronary artery from the aortic root, and it seems to be enlarged. going further down the interventricular septum, you see that there is a wide orange jet that seems to be coming from the inferior wall toward the anterior wall, or from the infroseptal area to the anteroseptal area. And here you see a diastolic flow opening into the apex of the right ventricle in the four-chamber view. So all these findings are consistent with a coronary fistula draining from the RCA, explaining why the RCA would be enlarged, and draining into the right heart and main pulmonary artery. The patient has a normal size left ventricle with normal function. She doesn't have mitral regurgitation. So what would be the next step? So as I told you at the beginning, if we're looking at coronary anomalies, we should either do a coronary MRA or a coronary CT. A coronary CT has a higher spatial resolution. In this case, we did a coronary MRA, and we were surprised to find that this patient actually has an anomalous left coronary artery coming from the pulmonary artery, or an Al-Kappa. Usually in adults, an unrepaired Al-Kappa will lead to substantial left ventricular dysfunction with ischemic sequelae in the territory of the left coronary. In this case, the patient was lucky. There was only fibrosis of a single papillary muscle, the anterolateral papillary muscle, by late gadolinium enhancement imaging. And this example, especially when you look at the coronary angiogram, illustrates that an unrepaired Al-Kappa actually has the same physiology as a coronary fistula, because all the blood flow to the myocardium comes from the RCA, but with developments of collateral, the Al-Kappa becomes a low pressure exit point for coronary flow, draining into the pulmonary artery. So because this patient most likely had at least relative ischemia explaining her chest pain, she underwent translocation of the Al-Kappa from the PA to the aorta. This is a postoperative MRA showing that the reimplanted LCA is widely patent, and she has been doing well since then. So to conclude, let's go back to the question that started this section. So what would be the next step in imaging in an asymptomatic patient with repaired tetralogy of Fallot and severe pulmonary regurgitation? The next step will be to do CMR to evaluate right ventricular volumes and to determine if the patient has a potential indications for pulmonary valve replacement. So thank you for listening, and I will see you back for the aortic imaging section.